Hey folks, it's Beth Wright providing you a podcast for Unit 3, Chapter 12 for your NUR 236 Pharmacology class. And these are drug therapies for the treatment of cancer. And we need, first going to talk a little bit about cancer and, thinking about how that kind of takes place in the body. Different things that can cause that. You have on this unit in your Blackboard site a table, a worksheet, if you will, that's provided, and you need to be sure to print that, take a look at it, fill it out, fill all the columns out in there so that you will know about these drugs, because again, those are your exemplars for this unit. So be sure to take a look at that table and work on that table. That will help you prepare for the quiz and the test. Okay, so again, let's talk a little bit about cancer. It is an uncontrolled cell growth, and it's invasive and metastasized with numerous etiologies, numerous clinical manifestations, and treatment as well. And so we've got the cell cycle, cancer cell cycle, but you need to think about cells in general. So all cells have a cell cycle in which they divide and replicate. All cells do, including cancer cells. And you know that, remember studying about HIV, how that as a virus, again, it is a cell. It takes off in the body and replicates, divides, replicates, divides. And during each phase of the cell cycle, different things happen. Biochemical events happen that are necessary for that division and for that replication. And when we hear the words division or replication got to think about that requires RNA and DNA. It's mitosis. And so thinking about our biology that we had years ago, and just thinking about how cells do that. And so we got to consider what happens when cells grow from the beginning to where they become a mature cell. And there's things that they're going to have. There's enzymes, there's protein, there's folic acid, there's all kinds of different things that cells have to have in order to do that division and growth. And we refer to that whole dividing, replicating, all that stuff as a cell cycle. And so it is with cancer cells as well. And this is going to be important in that you understand that that's how chemotherapy works. It works on specific parts or phases of that cell cycle. And so, it's not going to be important necessarily for you to know, oh, okay, well, this chemo works in this phase of the cycle. No, you don't need to know that, but you just need to know, okay, I understand why chemo is scheduled the way it is, because that's going to have the greatest impact on being adverse to the cancer cell growth. Okay, so that's the whole point in me even talking about that. So cancer develops, there's multiple causes, and we realize that. Environmental factors, exposures to chemicals, cigarette smoking, too much sun. So we know there's lots of different environmental factors out there. There's genetic factors as well. That's why we ask the question, do you have a family history of cancer? We know that there is definitely a familiar tendency with cancers. My mom had colon cancer, and we as in my sisters, we all have our routine colonoscopies to check for that. I mean, we know that. So we know there's genetic mutations that happen. We know that there's something that we pass along to each other, unfortunately. One of those things we wish we didn't inherit, but however, it is, in fact, one of the things that we do inherit. Normal cells versus malignant cells, we know that they reproduce in response to the need for tissue growth and repair. So when somebody has surgery or has some kind of tissue issue going on, automatically there's cells that, start growing and repairing there. And the need, when the need's met, they stop that reproduction, and it's well differentiated in appearance and function. And so we realize that, and we many times tell patients to do certain things to help with that repair and growth of cells, such as eating healthy, and certain foods are better to eat, certain vitamins are better to take in. Malignant cells, on the other hand, take a life of their own. They start functioning. They don't look like human cells or normal cells, human cells, normal cells, but they certainly act like one, and they occupy space. There's no purpose at all other than harm. They start getting blood supply and nutrients from normal tissue. And they grow in an uncontrolled fashion, and they're undifferentiated, meaning they're different looking than our normal cells. And then they can break off and metastasize adjacent tissue or circulate throughout the body in the bloodstream. And we refer to that as metastasis of the cancer when that happens. We know that there are hematological types of cancers. That's where the bone marrow is invaded and the lymph tissue. So leukemia, lymphoma, and multiple myeloma. Multiple myeloma is of the bone marrow, the cancer of the bone marrow. Or there's solid tumors or neoplasms. Carcinomas are of the epithelial tissue, and sarcomas are of the connective tissue. So when we talk about grading, so let's say that someone has a tumor and they do a biopsy. So that's how the grading and the staging is done. Your lower grades are better to have than your higher grades. So grade 1 and 2, they're similar to normal tissue, and they show some cellular differentiation. Whereas grade 3 and 4, they're unlike normal tissue, less differentiated, and more malignant, meaning more cancerous. Staging then looks at, is it a localized tumor or cancer, or is it metastasized where other organs are involved? And that's very important because that's going to decide on, the type of chemotherapy, both based on the grade and the staging. So localized tumors, there may be surgery involved, radiation, or concurrent chemo and radiation. I mean, I've seen where they'll do radiation first to shrink a tumor, and then they do surgery. So, it just depends on the oncologist. Metastasis will require systemic chemotherapy, and so that's something we have to think about as well. Protocols are developed too for specific types of cancer and those grades and staging as well. So protocols, what I mean by that is chemotherapy protocols. There's lots of clinical trials going on where they're testing constantly therapies to treat chemotherapy, and those are even some local clinical trials as well with the oncologist, and those prove to be beneficial as far as helping to eradicate cancer or to, definitely stop the growing of it and maybe placing the patient in remission. And when we mean that, we mean the patient still, when we say that, we mean, with remission, patients will still have the cancer, but it's at the moment has stopped growing. So that's a good thing when somebody's in remission. So again, treatment overview, we have surgery and radiation and chemotherapy. And these can all be done in combination. The chemotherapy, the goal is to eliminate or control that cancer growth and to relieve symptoms and to improve the quality of life. So these are our exemplars for this unit, and I tried to fix these so that they would be kind of in some order other than the way they are in your syllabus, so that you could kind of make some sense of them. But our first group of medicines are our alkylating drugs. We got the cyclophosphamide, vincristine, oxaliplatin, ifosfamide, carmustine, and then underneath the alkylating drugs are your antimetabolites, the methotrexate, and the fluorouracil. Now, the alkylating drugs damage the DNA of the cell cycle, so that's where those come into play. The antimetabolites are still listed under the alkylating drugs. They're just a different type of that, and they interfere with the sources needed for cell growth, such as folic acid. So if you think about metabolites, metabolism, folic acid needed for that, that's the way you can remember that. The next group is your anti-tumor antibiotics, and the one big one there is the doxorubicin. And the anti-tumor, we'll see, also underneath those are your plant alkaloids and the miscellaneous. And so these produce tumor destroying effects by binding with the DNA, and that's how these medicines work. Then your biological antineoplastics, those are, we've actually studied these already in Unit 2, but the monoclonal antibody, see at the end of those, the MAB, the MAB. So we've already kind of taken a look at that. These are the ones that use that biotechnology to develop them, where they use DNA technology. And the monoclonal antibodies use that recombinant DNA technology that can cause cell death or help recruit other elements of the immune system to attack the cancer cells. The protease inhibitors affect the proteasomes involved with cell growth. And then we have our anti-neoplastic hormone inhibitors, and so these are non-cytotoxic because they're dealing with the hormones here. They kind of turn off the hormones, so they inhibit hormones. And if you think about someone who's doesn't have hormones anymore or has low hormones, what should come to mind there is your postmenopausal females. And what do you see with those people? They are hot flashing, they're surging, so to speak. And so any kind of hormonal type of thing or the lack of hormones is what you're going to see with these patients. So we have the anti-androgens. The LHRH is your luteinizing hormone. And that one is dealing with is the Leuprolid, and then the anti-estrogen agents, the tamoxifen. So these are again inhibiting the hormones, and you know what that means. We have the cytoprotective drugs, the Mesna and the let's see, leucovorin. Have to get started on these words the right way. These are medications that are used to reduce the adverse effects of cytotoxic drugs, and some of those adverse effects can be life-threatening. The Mesna is used for major bladder irritation, hemorrhagic cystitis even, so be sure to review that. Leucovorin is used to help with the toxic effects of methotrexate and other types of chemo. And then we have our allopurinol, the anti-gout medicine. And the reason why that's listed here is because one of the serious side effects is the tumor lysis syndrome that you need to be sure to read about. We don't talk too much about it here, but you need to read about it because that's why this drug is there. One of the side effects of chemotherapy is the tumor lysis syndrome, and it includes uric acid being elevated. So the allopurinol is used to help with that. So be sure to review about tumor lysis syndrome. Okay, then again, these are certain medication groups. Traditional cytotoxic. Cytotoxic means cyto is cell, toxic is toxic. So we know that these medicines are, with the name like that, are going to be damaging to the cells, right? And we got the biological targeted therapies, which can also be cytotoxic. And then we have our hormones, which are hormone inhibitors, I should say. And we know that those are not cytotoxic, but they still can cause a lot of adverse effects. And then we have those cytoprotective meds. Okay, so an overview is our chemotherapy is used to treat cancer, and it can damage or kill cancer cells, and it's used to cure, prevent, relieve symptoms, or prolong survival. However, you have to know that the chemotherapy doesn't say, oh, when it gets in the bloodstream, it doesn't say, oh, you're a cancer cell, I'm going to get you, and oh, you're a normal cell, I'm going to stay away from you. It doesn't know that, okay? So that we have to understand that the chemotherapy is damaging to all cells. And so again, this goes back to that whole protocol, chemotherapy protocol, and why it's given in a schedule such that it is, because we have to give the body time to recover from the damage that chemotherapy does to the normal cells. We got to give the body time to heal, to grow back new normal cells. So it's a fine line between all of that. So you may see some folks who have chemotherapy twice a week, or 3 times a week for 6 weeks, or 4 weeks, and then they're off a couple of weeks, and then they come back 4 weeks. So each protocol is different, but they're scheduled like that because of this very reason, as well as trying to hit that cell cycle to do the most damage to the cancer cells. Most regimens involve a combination of drugs, and we have to understand that there is drug resistance that can occur with these medications. And so those cancer cells are smart, and they can become resistant. Just like with any other type of medication, like those to treat HIV patients, those folks can become resistant, and so that's why you see a combination of meds used. Just like with antibiotics, people can become resistant with that as well. Usually administered in cycles. So again, we talked about that, and it's done to make have the greatest impact on the cell cycle, as well as allow a recovery period of those normal cells to come back. And of course, medical oncologists are the ones that help us with treatment there. They're the ones specially trained. So, talking about our traditional cytotoxic anti-neoplastic drugs, most of them kill malignant cells by interfering with the cell replication, and they're active against rapidly dividing cells, both normal and malignant. And so, when we think about that, we have to think about those ones, especially the rapidly dividing ones. Those are the ones like your cells of your hair growth, cells of the GI tract or the oral mucosa. Those are rapidly dividing cells, and so that's why you see a lot of times folks lose their hair and always tend to have nausea and vomiting with as one of the side effects of chemo. Indications for cytotoxic neoplastics, of course, to cure certain cancer diseases and to relieve symptoms of certain cancers and to induce or maintain remission. And also you'll see some of these used for malignant conditions such as rheumatoid arthritis or psoriasis, those autoimmune types of conditions. So the drug selection and dose is dependent on the type and stage of the cancer, the drug efficacy, meaning, how well is it working. Also the patient's age and health status. So, a lot of times we have situations where, you see our older adults who have cancer, and they also have many other comorbidities or other conditions that can cause them problems. So, the liver and the kidney function is many, many times involved in this. So are cardiac and pulmonary. And so doses have to carefully be, adjusted for any kind of situation like that. So again, the patient's age and is going to be considered, as well as their functional status and nutritional status. What's their labs showing? All of that's going to be considered. Most doses are calculated according to body surface area, and doses may have to be reduced if there are issues with the liver or the kidneys. Now, one of the things about the protocols is when protocols are done or developed, I guess you can say, then those are based on, okay, well, this is how you're going to get the greatest benefit is by staying on this schedule and taking this chemo this many times a week or whatever the schedule may be, as well as that dose. Anything that causes the dose to be reduced or delayed can cause a reduction in the patient's chance for recovery or for remission or for a cure. So it's critical that we keep the patient as healthy as we can during the time that they're receiving chemotherapy, and we need to be teaching the patient how they can stay healthy and ways that we can do it. Of course, frequent hand hygiene. That's the biggest combat against infection. So what teaching are we going to provide for that patient for them to be healthy, and what are we going to do as nurses caring for these patients to keep them healthy? If there is a low blood count that affects the patient, and we're talking the WBCs to fight off infection, red blood cells, and platelets, then you might see immunostimulants given, such as what we studied about in Chapter 9. The routes of administration for chemo is going to be lots of different ways. There's intravenous infusion, there's tablets, pills, wafers, which can be implanted into the brain, seeds implanted into the body cavity, and that's referred to as brachytherapy. That is where they literally implant chemotherapeutic agents into the body. And also intrathecally they can implant chemotherapy. Now the administration, typically when we give IV, we're going to use some kind of a central vein, central line for this, such as a portacath. Peripheral IV sites are not routinely used just because of the danger of extravasation. And, you know, that can be a very, very bad thing. We got to verify IV placement with these patients. We got to confirm that we are patent and that we are in the vessel. And, you know, you can, first off, as a nursing action, we will look for a blood return. It is not to infuse a flush. That's not how you tell if we're patent or we're in the vein. The way you tell that we're in the vein is to check for a blood return. And then they can also use radiological dye to confirm placement as well. Only certified nurses trained to administer chemo should be given that. And when they prepare chemotherapy, the pharmacists, specially trained pharmacists, will do that under an environmental hood that makes sure there's no possible contaminants that can take place, as well as keeping their space safe for them so that they don't inhale the drug. Administration is going to possibly involve special tubing, so those things need to be followed for sure. And of course, all the time, baseline labs will be checked to make sure the patient's okay to check to have the specific medication. Specifically, we're going to look at that ANC, the absolute neutrophil count. The rate of infusion will be specific and should be followed. And again, we always want to check for patency. And then there's special gloves and mask and gown that's going to be worn when administering chemotherapy to patients. We've got to be sure to monitor for and knowledgeable about signs and symptoms of extravasation and infiltration for the patient. This can be extremely harmful to the patient. If that happens, they can lose a limb for sure. So we've got to make sure about that. And if the patient experiences pain, redness, or swelling at a site, we need to stop that infusion. Also, allergic reactions can happen as well, so the first sign of distress, we need to stop that infusion. And remember that cytotoxic agents can destroy the skin and tissue, and post-care of extravasation will depend on the type of agent that's gotten into the skin. Check this out on a little pediatric patient. This is a picture of extravasation. It's terrible of what can happen, and you can see, you know, it's just absolutely necrotic underneath there. It's terrible, and hopefully this child didn't lose their limb. We know that adverse effects are going to occur with our patients with chemotherapy, and those can include nausea, vomiting, Bone marrow for sure is going to be involved. And when we say bone marrow, we're meaning the red blood cells, the white blood cells, and the platelets, and also the hair follicles, because those are your rapidly growing cells there. And also many other kinds of signs and symptoms can happen. That tumor lysis syndrome was another situation that can happen as well, so you need to be sure to read about that. So again, here are some of our side effects. Fatigue, we talked about alopecia, anemia, and bleeding. Fatigue, mucositis with their mucous membrane having issues, our nausea, vomiting, our neutropenia, thrombocytopenia, and also several of the drugs are really hard on the heart, the liver, the kidneys, and the nervous system. Doxorubicin is an example of one of the heavy-duty chemotherapy agents that can cause some severe adverse effects and life-threatening even. For instance, heart failure being one of those. And so signs and symptoms of heart failure, checking the patient out for that prior to them receiving the medication needs to be done. So like an echocardiogram, we want to know that ejection fraction of that echocardiogram to determine that heart failure and other signs and symptoms as well. So this is a picture of that doxorubicin, also known as adriamycin, and I do believe they call this the red devil, just because of its wicked side effects. Safety precautions are taken when administering medications and for the patient as well. So all of these medications are teratogenic, so we got to avoid exposure while pregnant. And they're also carcinogenic, meaning that they can cause cancer. It's funny how some medications, such as meds used for dysrhythmias, any meds used for cardiac dysrhythmias can cause dysrhythmias. Likewise, chemotherapy drugs can cause carcinogenic effects as well. Perennial solutions are irritating to the skin, mucous membrane. We need to avoid the direct contact there. Wash hands thoroughly after administration is going to be really important. There's just, if any of these medications also happen to spill out on the floor, or there's anything like that happen, there's special spill kit that's used. It talks about this in your textbook. And then last but not least, cytotoxic and anti-neoplastics for special populations. Children, especially with children, in your textbook it talks about these on page 208. They have made great advances with chemotherapy and cancer treatment with children, and that is awesome. However, there's a lot of long-term effects due to this, or due to the treatment, and so follow-up is going to be extremely important for any pediatric patient. Of course, with our older adults, we know that they have more comorbidities or more medical diagnoses, so it's typically harder on them to go through the chemotherapy. The renal impaired and hepatic impaired, each of those chemotherapy agents are specific to what they can cause or what issues adverse effects may cause. So be sure to read about that. And then of course home care, there are the chemotherapy agents that are pills and the patient takes on their own. So teaching is going to be important about that. Okay, this concludes your podcast.